Hello and welcome to Paracetamol Academy. This is Malal Vishdan and today I'm going to be explaining to you what are the general anesthetics. So first we're going to have an overview of the general anesthetics, then we're going to be talking about signs and stages of anesthesia, and then about the pharmacokinetics principles of volatile anesthetics, and finally about the mechanism of action of inhaled anesthetics. So, how can we characterize general anesthetics? They can cause reversible depression of the CNS function, resulting in loss of response to and perception of all external stimuli. They can also produce reversible sleep in addition to analgesia, and they can suppress reflexes, produce muscle relaxation, produce amnesia, but it is very important to make sure that they do not suppress respiratory and cardiovascular function. As we can see in this table, the stages of anesthesia are divided into 4 stages. Stage 1 is called analgesia. Stage 2 is called delirium. Stage 3 is surgical anesthesia. And finally with stage 4, which is respiratory paralysis. We're going to be talking about each stage and diving more into its details. So for stage 1, which is the stage of analgesia, it starts from the onset of drowsiness to loss of consciousness, and it is suitable for surgical procedures not requiring extensive muscular relaxation. It also includes analgesia, as we said, amnesia, and euphoria. For stage 2, which is delirium, it is from the time of loss of consciousness to the onset of a regular pattern of breathing and disappearance of the eyelid reflex. This stage is very dangerous because there are uncontrolled movements, and we want this stage to be very quick because we risk the patient having blocked airway due to the irregular breathing and vomiting. For stage 3, which is stage of surgical anesthesia, it is from the onset of regular pattern of breathing to cessation of respiration. In this stage, the heart rate and breathing become stable, unlike in stage 2, and it is also divided into 4 planes according to the depth of anesthesia. And in plane 3 and plane 4, we have paralysis of intercostal muscles in plane 3, and in plane 4 we have disappearance of muscle tone, which is a sign of overdose, and it is the beginning of stage 4. Also, it is very important to note that if the patient was in stage 3, we should make sure to keep him in plane 2 or 3 in order to avoid plane 4, which is a sign of overdose. Stage 4, which is stage of respiratory paralysis. This stage lasts from onset of apnea to failure of circulation and respiration and ends in death, and this happens in the case of overdose. Now we'll be talking more about the pharmacokinetic principles of volatile anesthetics. So when the patient inhales the gas, they also inhale the air with it, and then it goes to the alveoli, and then to the blood, and finally to the brain. And it is very important to note that this process is reversible, which means that when the gas goes to the brain, it can also go back to the blood, to the alveoli, and then the gas will be exhaled. Equilibrium is achieved depending on the concentration of anesthetic used and on its physiochemical properties, which means that depending on its lipophilicity. So if the drug is too lipophilic, it means that it's not soluble in the blood. We're going to have a fast induction and recovery. However, if it's soluble in the blood, we're going to have a longer time to reach the brain and a slow induction and recovery. Now, what is blood gas partition coefficient? It is the ratio of the concentration of anesthetic in blood to that in the gas phase at equilibrium. It is also used to express the solubility of an agent in the blood. So, if this ratio is high, the anesthetic is more soluble in the blood. And at equilibrium, the blood to gas ratio is always equals to 1. Anesthetics that are poorly soluble in the blood, which means that we have a low blood to gas partition coefficient, they require less time for the blood saturation. And this means that we're going to have a rapid onset of action. And we're going to be following the same process we discussed earlier in the last slide, in which that the gas will be inhaled, it will be transferred to the alveoli and then to the brain. And these drugs don't require high concentrations. However, anesthetics that are more soluble in the blood, they have a high blood gas partition coefficient, they take longer time to saturate the blood compartment, thus a slow onset of action. So if it's water soluble, it would reach the brain slower, which means that it enjoys staying in the blood. For tissue-blood partition coefficient, for example in fatty tissues, the partition coefficient can be large in case of lipid solubility of the anesthetic agent. So in fatty tissues, they favor lipophilic drugs, and we're going to have a partition coefficient of tissue-blood high. And also, for example, in the brain, we're going to be having a high blood flow, so high perfusion, thus a high accumulation of the anesthetic agent. However, in the adipose tissue, we're going to have a very low blood flow, thus less accumulation of anesthetic agent. Also, the rate of blood flow to an organ will also influence the rate at which anesthetics reach their size of action, as we said right now with the example of the brain and adipose tissue. So the brain, liver, and kidneys, they have relatively high blood flow, thus a higher accumulation of the anesthetic agent. For the reversal of anesthesia and recovery, it requires reduction of anesthetic concentration in the brain and parallels with induction. So we should stop delivering the anesthetic to the lungs. Also, anesthetic diffuse back from brain to blood, and finally it can be expired or exhaled. How can we determine the potency of anesthetics? We have something called MAC, or minimum alveolar concentration. It is the concentration at 1 atmosphere of anesthetic in the alveoli that is required to produce immobility in 50% of patients subjected to surgical incision. It is also expressed as percent volume in air. For example, we're going to have anesthetic plus air, 50% anesthetic and 50% air depending on the agent. It is also used as a measure of the potency of the anesthetic agent, and the MAC values typically refer to 40-year-old individual, and MAC decreases usually with aging. Now let's have an example in order to understand more the potency of anesthetics and MAC. So, if MAC of an anesthetic agent is 20%, it means that the patient is going to have 20% of the anesthetic agent plus 80% of air. Also, if I gave the patient 1.3 MAC and the MAC of this agent is 20%, what I can do is I do 20% times 1.3, which is the MAC, and we're going to have 26%. This 26% is the anesthetic to the patient given. Now this table is going to be summarizing the MAC and the blood to gas partition coefficient and the oil to gas partition coefficient of these agents. Let's take for example nitrous oxide. Nitrous oxide has a MAC of 104%. This means that it is the least potent because, as we can see in the table, it is the highest MAC present between these agents. Now on the other hand, we can take a look at methoxyflurane. Methoxyflurane has a MAC of 0.16%, and we can deduce that since it is the lowest MAC, it means that methoxyflurane is the most potent, and it also has the highest blood to gas partition coefficient, which means, as we talked before, it has a slow induction and recovery. This is the reference that we use in this chapter, and feel free to look at it in case you want to look further into some topics. Thank you so much for tuning in, and stay posted for Chapter 7 Part 2. And in case you have any question, feel free to ask it in the comments section. Thank you.